For the last several years, the CT is getting bigger. Now, the size-wise, from outside, you probably won't notice, but the detector has become much bigger. From the workhorse of 64-slide CT, where the coronary CTA took off, and that's at least the lowest standard CT scanner you need in order to perform coronary CTA. And it's getting bigger, meaning they can cover more in the cranial caudal direction, or z-axis, as we say in the CT. So basically, with the 64-slide CT, you cover 4 centimeter. With the newest 256 or 320, you cover about 16 centimeter, because each detector that you see here has a width of 0.675 or 0.5, depending on the manufacturer. And then you multiply by that, and that's what the number you got. Okay? Okay. This is how usually CT work. With the new CT scanner there's 2 manufacturers who manufacture this white detector CT. One is 256 detector, one is 320. They all cover 16 centimeter. Essentially, most of the heart, I would say 99% of the heart, could fit into that detector. So you can see the patient really doesn't have to move. We can position the heart in the middle of the detector, and the scanner rotate, the gantry rotate once, and you got a snap picture of it. So, I mean, if you think about it, it's pretty incredible, because in order to get an echo, I mean, how long would it take, right? In order to get an MRI, probably even longer. With CT, essentially with the heartbeat, you get the entire 3D picture, volumetric CT data set. So the acquisition time is really become incredibly short, okay? So this is the example how the image acquisition with 64 slides, you need to obtain 4 rotation at least to compose the entire heart, okay? With white detector CT, basically with 1 rotation, you get the entire heart. This is just an illustration of what it would be like taking a picture of a medical center from far away, and you can see right there to notice the difference is with white detector CT, the image you get, the whole heart, actually is exactly at the same time, okay? Where when you compose 4 sets of picture into one, you compose 1 picture, the time that you get from the first picture and the 4th picture are not the same. And this bears the importance of when you want to do myocardial perfusion, okay? Does that make sense? The time is essential for perfusion, right? So if the top part of the heart is not the same, it wasn't acquired at the same time as the bottom part of the heart, you can't really compare the attenuation factor, okay? With white detector CT, you get rid of that problem. This is some data that's been published. I mean, you can see here with the 64 slide CT, you can tell from this what we call step artifact. You can see this slab was acquired in one time. This is in 2nd, 3rd, and 4th. You can see they all have slightly different contrast intensity. Okay, and that when you compare the attenuation factor of the myocardium here and here, you need to be aware of the one acquired at the same time. Versus in the right-hand side, all the images are homogeneously displayed, and I mean they all acquire exactly simultaneously. Okay. So, and that's also useful for a patient with arrhythmia, right? I mean, if you have reasonable R interval, and then even the patient is an AFib with single V acquisition or 2 V's acquisition, you can have a very good image quality, and that has been validated in quite a few studies by now. With the white detector CT, atrial fibrillation, essentially, unless the heart rate is really fast, I would say over 100 or 110, you can acquire diagnostic images. So AFib is no longer a contraindication for coronary CTA, okay? I just want to clarify, for the fellow who has seen this lecture, some people might want to sell you a 640 size CT. Okay, is it really that big? Well, it's not true. When we talk about multi-detector CT, multi-slice CT, multi-row CT, I mean, what does that all mean? So number of detectors is not the same number of slices. Number of detector is actually physically how many detector the scanner has. Okay, 64 slices, 64 detector, most of them. So when you have 256, like with the newest GE and Toshiba, they actually have 256 rows of detectors and 320 rows of detector, okay? Do you know, Mo, you're gonna be how many detectors our force camera has?
It has 2 detectors, each one of them is 128.
Each one is 128. So you're saying that if I say 64 detectors cover 4 centimeter, you're saying our detector is we have 2 detectors who cover 8 centimeter each. That's not true. I'm sorry? No, 2 detectors.
But our coverage is like 12 centimeters. So that's like...
It's not 12 centimeter. They try to tell you that. See, that's therefore the confusion. Okay, so for G256 Revolution, they have actually 256 detectors who cover 16 centimeters, so as Toshiba 320. For Siemens is the most confusing one, okay? For the first generation dual source CT, okay, the prior generation, most of the people have or flash, monotone definition of flash. That's 2 detector of 126 slices. What does that mean? This is actually 2 detector of 2 heads, two heads with 64 detectors. So actually, but they do what we call Z-flying focal spot technique. Basically, electronically, it moves the focus up and down the Z-axis. So each detector was sampled twice. So it produced from 64 detectors into 128 slices. So you have 2 head with 64 detector each, so the coverage is only 4 centimeters. With the force, they added is actually 96 detectors. Okay, so 96 detector with 192 slices. So the coverage is only 6 centimeters. Does that make sense? So our Siemens scanner, dual source scanner, is actually the smallest compared to even Philips. Philips is 128 detectors or 256 slices who cover 8 centimeters. Okay? The reason is simple, right? It's impossible engineering to mechanically, from engineering standpoint, to have 2 heads of 256 detectors. That will be, the gantry won't be moving that fast, right? So this is very important for you to understand. Our force scanner only covers 6 centimeters. Okay. Okay. So this is a technique. So basically, this is summarized. Okay, the number of detector rows in the longitudinal axis, Z-axis, the number of slices are now the same. Okay, so you can double number of slices with this technique. So 128 detectors can produce 256 slices. Okay. Okay. The scanner is getting faster, and why is that important? Obviously, cornea moves, okay? The faster your scanner, easier for you to freeze the images. You can see there, I'm sorry, especially the RCA, the crux RCA moves a lot, and that's mostly, not always, right? That's where most of the motion artifact produced, okay? And the temporal resolution of the scanner is determined by the gantry and rotation speed. And before, with the older generation scanner is mechanical rotation, there's contact, friction, so the fastest you can go is probably around 300, 350 milliseconds. With the new contactless, I think they put air inside the gantry, so there's much less friction. Now the scanner can rotate at a rate of 250, 280 milliseconds. Obviously, the larger the scanner, slower the gantry rate because of the weight. And this is to give you an idea of the speed of rotation of the older generation scanner. Well, it's actually the same scanner. We just program in the different gantry speed. Remember, you can program the gantry speed as slow as you want, or it can be static if you want to. Okay, so you see in the right-hand side, this is how our force scanner operates. It's the fastest of all the CT scanners so far. Okay, so temporal resolution is gantry rotation time divided by 2, because you don't need to rotate 360 degrees. You can just rotate 180 degrees and get the data you need. And if you have 2 detectors, you only need to rotate about 90 degrees, actually 92 degrees, because you need some type of overlap. So temporal resolution, our new scanner is 62 milliseconds. The other innovation of the dual source CT for necessity, right? Because imagine if you have a white detector CT, you don't need to move the patient, right? I mean, you rotate the whole heart, 16 centimeter coverage, that's it. If you have a smaller scanner, like our force, we cover only 6 centimeter, you need to move faster, if you want to take the picture fast enough. Okay, so you move. So they have this high pitch mode, meaning that the patient can move in and out of scanner, in and out of field of imaging at a rate of 87 centimeter per second. Actually, I tried it one time when I was in Germany, and you can, it looks fast, but it doesn't feel that fast, believe it or not. It's not like a roller coaster or something. And this is how it works, okay? So essentially, the table moves so fast, you can image the heart, 12, 16 centimeter in, you can do the math, right? The table moves 87 centimeter per second. You only need to image 16 centimeter. You can acquire the image in less than 1/3 of a second. And why is this important? I'm sorry. I just want you to, what's the main, so looks like it was imaged within 300 milliseconds. What's the difference between high pitch mode image obtained with high pitch mode, which you get a picture in 300 milliseconds, versus the image you obtain from white detector CT, you can image that in 300 milliseconds for the gantry time. Same problem what I mentioned earlier, right? With the white detector CT, the whole heart is imaged exactly the same time. With this high pitch mode, give you the illusion that the whole heart is imaged exactly the same time, but they are not. It's so fast. It looks like it's all single exactly the same time, but it's not. The beginning of the scan, the top of the scan, is 300 milliseconds earlier than the bottom of the scan. So that's, some people argue that that might be significant for myocardial perfusion analysis, but bottom line is, I think for practical purposes, for heart being only, you need to only move 12 centimeter. I think the difference is not significant.
Dr. Chang, what does it, the machine is triggered at the percentage of the hour on the interval, or is it milliseconds, or is it?
You can program either way. Usually, yeah, you can program exactly where you want. And usually, obviously, as you can imagine, they won't recommend you do the most if the heart rate is too fast, right? Because you need 300 milliseconds. And why is that important? Scanning so fast. This is very important. Just to give you an example of the image that you can obtain from regular helical mode scanner versus flash mode. You can do essentially free breathing cardiac CTA, which is essential for pediatric imagings and trauma. And that allows us to perform TAVR or wide range scanning with reasonable amount of contrast. Imagine, in the old day with the scanner moving so slow, if you want to image the entire vasculature from chest all the way to pelvis, you need to pacify essentially the entire vasculature, and you need like hundreds cc of contrast. Now essentially the scanner is so fast, sometimes you can outrun the bolus of contrast. So you can just follow the bolus of contrast along the way. And with that, you can save. So this is the image that we obtain when we start one of the first cases, which I wish all the cases are like this, high quality. The whole entire scan was done in 1.4 seconds. Okay, so again, I mentioned this earlier already. The contrast you need, depending on duration of the vascular contrast or classification, when you pass through the field of imaging. So smaller the detector or slower the acquisition speed, more contrast, right? So with this, people have reported, using 20, 30, 40 cc of contrast using this newer generation scanner. And with the newer development of spectral CT, which I'm not going to talk about today, with mono energy imaging, you can, maybe not coronary, but you can obtain vascular imaging of the aorta, entire aorta, for as low as 20 cc of contrast. And people are working aggressively on this because essentially eliminate the contraindication for renal insufficiency. Okay. Anyway, so that's the dual energy that I mentioned. So this is a summary of what I just mentioned, that the standard 64 slice CT versus the newest generation is the gantry speed is a lot faster, therefore better temporal resolution. Therefore, you can perform images, coronary CTA, a much higher heart rate. In a lot of places they advertise, they brag about, they perform routinely cardiac CT without beta blocker. Bottom line is, slower the heart rate, image quality is still better. Well, we know for TAVR imaging, we don't give beta blocker anymore, and you get, I would say, diagnostic images, even for coronary. And detector detector is getting smaller. I don't know if you all went to Dr. Lima's talk and imaging over the weekend. I mean, they're basically manufacturing detector with a 0.2, so you can have spatial resolution of 0.2 millimeter, which is very close to coronary angiogram. Okay, and Z-axis coverage has increased significantly. Scan time, basically one single heartbeat, less than 1 second. You can do monochromatic. We can talk about maybe next time. A lot of new software to help you save radiation, choose the phase of the cardiac cycle with the best images. You can use much less contrast. And For heart rate control, I mean, it's still necessary if you want to get picture. So last part of my talk, this is the part I just put it out this morning because believe it or not, I usually give this talk in May. For whatever reason, Dr. Shah is not here. He put me on February. I saw in my calendar yesterday, and I refused to believe because I still have the old copy, old schedule of saying I'm presenting in May. And Dr. Nabi told me this morning, you're presenting today. So I am indeed presenting today. So I put it up this morning because I thought there was a lot of confusion. Okay, Mawash, you've done a lot of CT. What's 4D CT for you?
I don't think it's anything different, just from it's like more of a, you know, a volumetric assessment and also look at the valves and the heart in motion. That's 4D for me. It just adds a dimension of time.
Yeah, exactly. So basically you have 3D data sets or volumetric data set displayed in time. What's gated CT?
So gated means that you basically time it to the cardiac cycle. So basically that's gated. So systole, diastole, and accordingly heart rate.
Okay. Is echo gated?
No.
No? You want a different opinion?
Echo gated. I've never heard that term in echo.
Is it gated? Meaning the image that you see
Real time.
is real time, yeah? It's not exactly gated, but it's ECG, is ECG trigger. So basically, you can differentiate if it's systole or diastole, okay? Nuclear is ECG gated, right? But it's a composite of multiple systole and diastole put in together. How about CT?
It is like nuclear.
It is a nuclear, you all agree or not?
So so okay, you time it, you do use ECG as your trigger, right? And then you do systole and diastole.
So it's more like echo, right? It's not a composite of multiple systolic phase. Sure, I mean, you have different, the top CT, the 64 CT is almost like 3D TE, okay? Then you need to stitch together because you need different, it's obtaining different cardiac cycle, right? But if you have white detector CT, it's more like 3D real time. Is that making sense? So 2D is all real time, right? The systole you're seeing you're seeing exactly what happened. The whole heart is being imaged. With the 3D echo before, when the heart rate is fast, you need a stitch because you can't obtain the entire heart in one single heartbeat. So you need to put several heartbeats together. CT, 64-6 CT is like that, but with a white detector CT, it's more like 3D real time. So essentially, you get entire heart, seeing the real time in systole and diastole. What's dynamic CT?
I think it's just a term that someone invented to confuse everybody else.
No. Don't be, you're too young to be sarcastic.
I don't know. I feel like it's the same thing as 40CT.
It's the same. Okay, I want to try to demystify, or whatever you want to call it. What's dynamic imaging? CT. When you inject contrast, you want to enhance the cardiovascular compartment, right? That's essentially what CT does. So dynamic CT means that you take sequential scan of certain structure of interest, time over time over time, okay? So basically, dynamic CT, what imaging modality does dynamic CT all the time? MRI, exactly. So you inject contrast, you take picture before the contrast arrives, and you see how the contrast get into the, in the arterial phase, and you see how it get to the tissue, how it exit to the vein and disappear, and then recirculation, right? In the cath lab, when you do thermal dilution, right? I mean, that's you basically measuring, instead of taking picture with thermal dilution, you're measuring temperature time over time, right? Determine the physiology of the circulation, right? So you generate what we call time attenuation curves, right? You can put your region of interest. Let's say if you want, you can put your region of interest in left LV cavity, myocardium for myocardial perfusion, or anywhere you want, okay? And the trick here is could be ECT, it could be gated or non-gated. Let's say if you want to do perfusion of the kidney, you don't need ECG, right? Heart is the only organ that you're interested that you need to do gated. Am I making sense? So the trick here is you need to differentiate between systole and diastole, which is cardiac phases, versus arterial and venous phase. So there's two components here. So dynamic imaging, CT imaging, most of the time refers to the arterial venous phases result imaging. Okay, you want to see how the contrast arrive, enter, and exit your region of interest. Whether it's gated or ungated, it could be gated or ungated. Okay? Does that make sense? So obviously, the application is you want to look at, it allow you to see the organ perfusion, and for our vascular surgeon, they're very interested in AV malformation, right? Because timing is essential for them. For most of the routine cardiovascular CT we do, for coronary CTA, we're imaging in arterial phase, right? So we're taking the whole heart, we're taking the picture of the heart, and hopefully you activate the scanner when the bulk of the contrast, the maximal attenuation occurs in part of the circulation you're interested in our case, our coronary artery, right? So that's where you take the picture. If you're interested in myocardial perfusion, static myocardial perfusion, okay, you want to image when most of the contrast is within the capillary or myocardial or tissue phase. Versus if you're interested in resynchronization, you want to image well the cardiac vein or vein of Marshall that Dr. Valderrama wants, then you need to image it a little bit later. Yes? So this is all static imaging that we obtain. And gated basically is arterial phase imaging, but we take the picture doing systole and diastole and display it. So 4D CT, as Mawash mentioned, is display a 3D CT data set in motion, which could be either throughout the cardiac cycle or systole or diastole, which I would say the most people refer to when they would say, can you do me a 4D CT for the cardiac CT? That's what they want. They want systole and diastole, arterial phase of the heart, right? But you can also do 4D imagings, basically display the 3D data set of an organ throughout the arterial and venous phase. That's also 4D imaging. But that's not what most of the people refer to. So bottom line, I would say most of the people agree when you say 4D cardiac imaging, they want to see systole, diastole, okay? 3D data sets in systole and diastole. And for dynamic imaging, we mostly refer to image throughout the arterial and venous phase. Okay, let's see. John, this is 4D CT. It's 3D data sets and it moves.
I don't think your heart's like that.
It was an astronaut in space. No, it's not. I mean, this is a 3D data set during a cardiac cycle, most likely diastole, and I'm just rotating it, you know. So this is not 4D. This is pseudo 4D. Okay. Okay. Is this 4D?
The first one is.
What's the diagnosis here? Mo, what's the diagnosis here? 50 years old guy with chest pain, exertional chest pain.
I don't see the whole course of the diabetes of the microcardial.
That's in the beginning.
Yeah, there's a bridge.
Yeah, it's a complete myocardial bridge. We just happened to acquire the images, retrospective gating without dose modulation, for whatever reason. And here you don't see that well because display, I have to, you have to increase the, adjust the window so the whole thing's not buried. So this is tricky, okay? This is not a thin slices either. This is a thickened slices. So this is kind of not strictly 2D display, okay? This is about 3 millimeter thickness. So if you want to be rigorous about it, this is also 3D, but obviously I'm not going to argue about it. Okay, so you can see the, so this is one for coronary. Usually we don't do 3D, 4D imaging of the coronary because there's no clinical benefit or indication for that. But obviously for valve, this is important. So this is essentially a fast view of mitral valve, especially mitral valve prolapse. And so it looks like 3D TE, but what's the main difference, Mo?
This is not real time.
I think they
Well, okay, let's go back. Gated, 3D TE is also gated. In a sense, is system diastole resolved, right? Okay. This is stitched together, yes, with our scanner, but with 256 slices CT, you can show this, and it's not stitched. It's all real, exactly the same time. What's the main difference? If I show you this, what's the data set that you obtain from 3D TEE compared to 3D data set you obtain from CT?
Oh, this is a 3D data set started in TE based off of 2D.
You won't be able to see this as well. Remember, 3D TEE, you're imaging from HM through the atrial side. So the other side, you actually cannot see it, right, unless you go into transgastric view. All this image that you obtain, you can see entire subvalvular apparatus. There's no attenuation, well, there's some attenuation like any other, but there's no more attenuation in atrial side or ventricular side, okay? And all these images obtained in one single data set. So that's the main difference between what you get from 3D TEE of mitral valve, which you can look at the leaflet very well from the atrial side, but not so well from the ventricular side because of obvious reason, right? Because the ultrasound come from. And this is a ball in cage. I'm missing one, huh? Whatever reason, okay. So you can also do this with the aorta, okay? So on the left-hand side, it's a 2D display. So when you talk to a vascular surgeon, this is not the dynamic image they want. This is essentially 4D CT. And you can have this kind of display. So this is post-processed. So this is not real CT images, but you can display in different way. And, okay, so this is the most common indication for dynamics imaging for cardiac application, meaning for myocardial perfusion. As you can see here, this is an example using the white detector CT. And this is, for you guys who've done this MRI, I mean, this is very familiar to you guys. I mean, basically, yeah. Okay. The difference is we get better temporal resolution, and MRI has probably better signal-noise ratio. Okay. So what part of the cardiac cycle you usually acquire for MRI? Diastole, systole, for myocardial perfusion. Any fellow has done through MRI? Eric? Where? Which part of systole? So you guys image it throughout the systole? But I don't see heart thicken, move too much. So actually a snapshot, or actually you image it? I know it's a subtle difference, but systole lasts how long, approximately? 200 milliseconds, depending on heart rate, 300 milliseconds. So do you actually image entire systole or only part of systole? I don't know, I'm asking the question. Yeah, but each slice is which part of cardiac cycle? Which part of systole? CT usually you acquire the end of systole. So I'm not an expert, so I don't exactly know what's the rationale behind imaging end of systole, except for you have maximal thickness, maximal signal. Anyway, okay. So this is other application. This is all I got it from the vendors. You can see, essentially you can get peripheral angiogram run off with the CT. Okay. I mean, surgeon likes it. Okay, what kind of display is this, Mawash? Is it dynamic? Is it 4D? What would you label this?
It's 4D because the jaw's moving.
This image is for neuroimaging, for brain. Strict definition, this is a 4D dynamic, okay? Because you have 3D data sets, you have time, it's time resolved, but you look at, stop moving. But you see the arterial, you see how the contrast coming, into the arterial and then come back in the venous phase. So it's actually 4D dynamic. So this is a truly 4D dynamic imaging. And if you do it in the heart, it will be even more complicated, right? 4D ECG-gated dynamic imaging.
Why is our dynamic CT here, Dr. Chang, more radiation?
This one, because what does the radiation dosage, what determines the radiation dosage?
Well, we have the,
for the exact same amount of coverage. The weighting factor, exactly. Well, CDDI is, the more area you radiate, more dosage. But your weighting factor, what is weighting factor? But what is weighting factor?
Oh, it's basically how much...
how sensitive the tissue to radiation, right? So if I image the peripheral vasculature like this, I mean, you can take 100 scan. I mean, you're not gonna cause bone cancer. Let's put it this way. Someone with it. So head, I think if you, except for thyroid, it's pretty low weighting factor too. And chest, because especially for women in the breast and lung, that's why weighting factor is much higher. And that's why they only get about 4 millisievert. For myocardial perfusion, dynamic myocardial perfusion, okay? Usually the protocol cover about 8 centimeter, not entire heart, because you don't really need to cover entire heart to do myocardial perfusion, but you don't care about atrium, right? And do you care about apex? Maybe yes, maybe not, right? But usually 8 centimeter, you can cover all 3 coronary territory, right? If you take picture every 2 to 4 seconds, that's how the dynamic perfusion mode required depending on the heart rate. And you take picture 2 seconds, 4 seconds before the contrast arrive, and maybe 20 seconds later, and gate it with low kV, usually 80 kV, you get about 6 to 8 millisievert. Okay? So if you do rest and stress, because if you want to calculate coronary flow reserve, you get about 12 to 16 millisievert of radiation. I mean, it's significant, but it's something you don't want to repeat every 3 months or every year, but it's possible. It's not unreasonable, because the old day, still people do stress nuclear imaging, 2 days protocol, rest and stress high dose. That's about 12 to 15 millisievert. Okay. So, okay, let's get more example. For endoleak, it's obviously very important, right? You want to see, imagine in all day, you need to time it. You take arterial phase, delay phase, and if you time it wrong, I mean, you basically essentially it's non-diagnostic. With this, you can look at how the contrast get into the sac, and you can identify even the feeding vessel if you have to. I thought this was pretty cool, nothing related to cardiac, right? Usually, you know, for breast reconstruction, I didn't know. You know, we get if you're doing clinic, you get cardiac clearance all the time for reconstruction. And you ask, well, what's so big deal? It's a plastic surgery, right? I mean, turns out that the surgery lasts a long time, like 6 to 8 hours. And when they put the flap, they need to make sure all this small vessel doesn't get damaged, because if they get damaged when you harvest the flap, I mean, tissue's gonna die, right? So with this technique, you can identify the feeding vessel. And with the new display technology, I think they can kind of project over the patient's skin where the vessel is. So the surgeon know beforehand where the course of all these arteries and the feeding arteries and exit vein are. And the people done the studies say essentially cut down the time duration of surgery from 8 hours to 4 hours. I wonder if we can do something similar with the bypass, with the sternotomy in diabetic patient. They can avoid cutting some intercostal artery. Anyway. Okay. So this is all advertising mimic. Now I have 5D imaging. It's a patient with renal cell carcinoma. So you can see perfusion before the surgery. You can identify the tumor. And then the perfusion. Anyway, so again, I'm not going to show you this. So essentially with CT, if you've done properly and with a newer scanner, you can obtain a lot of information with very reasonable radiation dosage. The question is obviously like, what they used to say about MRI, about one-stop shop. Do you need to do all this, the same study? I mean, it's good to have options, but question, do we get all the information that we can in one single scan, or we just perform the scan that give us the information we need? I think it's more a philosophical question.